Hey guys, welcome back to yet another video. It's me, Ashil, and today I'm coming in the capacity of a NICU nurse. So for those of you who don't know and it's your first time here, welcome. I am a NICU nurse, and for my returning and loyal supporters, hey guys, thank you so much for your support. Please like, share and subscribe to my channel, and of course leave a comment. Let me know what you think about the channel, what you would like to see in future videos, and let's just have some conversation. Yes, so today we're going to do a NICU 101 video, which pretty much is talking about the basics in NICU nursing. This can be useful to nurses who want to go into NICU or want to get into the NICU field, as well as for parents who may have children in the NICU and are a little apprehensive or not sure what to expect. So this can benefit either or. So let's get right into the video without further ado. So guys, we're going to get right into the video. This is going to be a short video, pretty much just like I said, talking about the basics of NICU nursing. So what does NICU stand for? If you have no idea, if you have not heard anything about NICU nursing, please, I'm going to link my previous video up here. Just click, go watch my video, and then come right back here. Okay? Yes, but NICU, Neonatal Intensive Care Unit, right? And there are different levels of NICU, or the Neonatal Intensive Care Unit. Level 1 NICUs cater to babies who are born between the age of 35 to 37 weeks, and of course beyond 37 weeks to the 42 marker. This NICU is pretty much for level 1, like I said, is pretty much for term babies, babies who don't need really any intervention after birth. They are born fine. So if there's any little issue that they may need a little more observation for, then they go to the level 1 NICU. Level 2 NICUs, however, deal with babies below the age of 35 weeks, so between 32 to 35 weeks. This is a little, so the higher the level goes with the NICUs, the more intense the care is in that NICU. So the level 2s would cater to babies who need a little more intensive care. So probably babies who have jaundice, babies who, anything that doesn't really need like surgery or major interventions, then you would find in the level 2 NICU. So it's a step up from the level 1 NICU. So if your baby is in the level 1 NICU and is being observed for probably after birth, something may have happened during the birth and they're being observed and they do get worse, then they would step up to a level 2 NICU, right? With the level 3 NICUs, these cater to babies born below the age of 32 weeks rather. This is more of an intense unit where they deal with a lot of respiratory issues, babies who are born prematurely. These kind of conditions you would find in level 3 NICUs. Babies who also need minor surgeries may end up being in the level 3 NICU. This is the type of NICU I work in, the level 3. Level 4 NICUs, which is not available in St. Lucia, they deal with very, very, very critically ill patients who may need surgeries, may need transplants, may need very intensive care. So this is the highest level of NICU, and yes, so these are the 4 levels of NICU nursing. So why would your baby need to be admitted to the NICU? Of course, there are different reasons, various reasons why a child would need intensive care. For example, infection. Babies could be born through meconium stained liquor. Meconium meaning the first set of stool that a baby passes after birth or during birth at times. So you find that the liquor, the amniotic fluid that baby was in during birth, becomes stained, and that can cause some sort of infection. So of course you would need to monitor baby, administer antibiotic treatment, etc. So infection could be one of the reasons. Of course, prematurity, like I said in my previous video, this is a major reason for admission to the NICU. Babies born prematurely would, like I said, not have the full lung capacity. They would need respiratory support, and all of these intensive treatments. So that is another reason for admission to the NICU. Lower level NICUs would admit babies because of probably hypoglycemic issues, which is low blood sugars. They would also probably admit because of hypothermia or hyperthermia, or pretty much temperature. Somebody's passing with loud music. Sorry, it's not my fault. It's not at my house. Sorry if you can hear it. But because of temperature instability issues, so babies not maintaining temperatures would probably need to be placed under a warmer, etc. So that is another reason for being admitted to the NICU. Another reason for being admitted would be because of jaundice. Like I said earlier, babies, the yellowish tinge to the baby's skin, meaning that they would need a phototherapy. Also, poor feeding. Some children, they can't feed on their own. They have issues latching. They have poor suck, swallow, breathe coordination. So they would be admitted to the NICU to help with these issues. So these are just a very few reasons, few of the reasons why babies would need to get into the NICU. So what would you expect to see in a NICU, in a room where your baby's being kept? What would you expect to see there? So of course there would be a variety of equipment for that one baby, depending on how critical that baby is. So if it's just for special care reasons that babies are admitted, probably for jaundice, for feeding, nothing that would need severe interventions or very critical monitoring, you would find basic stuff in there, like your cardiac monitor. This would monitor baby's heart rate, the level of oxygen in baby's blood, as well as, probably depends on whether it's full cardiac monitoring or partial cardiac monitoring, it would also monitor baby's respiration rate, right? So more than likely baby would be on partial cardiac monitoring, which would only monitor the heart rate and the SpO2, which is the level of oxygen in the blood. So for a special care case like that, you would get your cardiac monitor. You would see an SpO2 probe, which is pretty much like a plaster which goes around baby's wrist or foot, which gives the reading to the cardiac monitor. So this is where the readings, the heart rate readings, the level of oxygen readings would come from the area on the wrist. So it's like a red light which would attach to these areas, giving off these signals to the cardiac monitor. You would also find, depends if baby is on some sort of oxygenation, you would get your humidifier, because we don't ever give dry oxygen to our babies. I don't think it should be given to anybody, but we don't give dry oxygen. So there is no time at all that you will come to find a nasal cannula, which is the medium by which we give the oxygen, attached directly to an O2 tank or directly to the O2 connectors on the wall. It will have a humidifier, which is some sort of container which has fluid in there, water, more than likely sterile water, which humidifies that oxygen that goes to our babies. Because the reason for that, dry oxygen causes the mucous membranes to dry up, and it can even get to the point where it bleeds. So humidified O2 causes some moisture, causes it to be, it's not too harsh for the babies, and of course we need that. So you would get your humidifier, you would have your cardiac monitor, you would probably see a suction machine, where if baby for whatever reason aspirates or whatever, you would have your suction catheters there by babies to just suction if any milk is in the nares or anything like that. So you'd have your suction monitor, your suction catheter, sorry, your suction machine. In every room, in every station, we have all our necessities. So you'd find needles, you'd find syringes, anything that we would probably need to collect blood for baby. You would get all of these in each room that babies are housed, right? And for this would probably be the most you will see around your less critical babies, your special care babies. I am sure I'm forgetting something, but yes. So we move to the critical room, the critical care babies, babies who are on ventilators. So in addition to what the special care babies had, which are the cardiac monitors, the SpO2 probes, the suction machines, you would get your ventilators. If babies are premature, they would need some sort of ventilatory support from the ventilators, so you would find that there are ventilators there. There would also be glucometers. This would be our instrument that we use to monitor the level of sugar, glucose in the baby's blood. You would have your stethoscopes. Each baby has a stethoscope that is assigned to them. So anybody coming to use that stethoscope would obviously have to clean, disinfect, sanitize before using it on the baby. But each baby has their own stethoscope. We also have ambu bags by each baby. An ambu bag is what we use to ventilate baby, manually ventilate baby via mask. So this would be our emergency ventilation. So these are majority of the things that you would get or expect to see in your critical care area in the NICU, in the patient care setting. So we spoke about what you would expect to see in the room when you get there, what equipment you would see, but what would you expect to see on your actual baby? So you would see cardiac leads, which do the same thing that the SpO2 probe does, but in addition to displaying your heart rate and your SpO2 level on the cardiac monitor, it would pick up your respiration rates as well. So for our more critical babies, we also do full cardiac monitoring. If it only displays the heart rate and the SpO2, then that is partial cardiac monitoring. So you would see your cardiac leads. You would see most likely an NG tube or an OG tube. This stands for nasogastric or orogastric. So as it says, orogastric would go down to the oral passageway into the stomach. The nasogastric tube would go into the nasal passages down into the stomach. And this would be how you feed a baby. Babies who are not feeding, who are critical, who are not breastfeeding, that is, sorry, or who are critical would need to be fed via these tubes. If babies are NPO, meaning not fed by mouth, we would have these tubes being vented, meaning attached to a syringe, an open syringe, just to release some of the pressure baby would get from the ventilator based on what settings that the ventilator is on, right? So babies inside of the incubator, you would expect more than likely they would have just their nappy, socks, and a hat. For babies who are intubated, they would have, of course, their ET tube in place, and this would be secured via the hat and what we call a bridge. So the bridge would be the visible part in going across the mouth. This would hold the ET tube that is in the baby's lungs in place, and that, of course, we would tie to our hats. This is how we do it in St. Lucia. So that is one of the things you'd expect to see if baby is in fact intubated. You'd also see tape, which we use a specific type of tape that we put underneath anywhere that the tube is making contact with baby's skin. We would put it under there so there is a barrier between baby's skin and the tubing. So these are a few of the things that you would come across on baby, that is, in the NICU in St. Lucia. Again, the higher the level, the more intense the care. So you would get other machinery, probably much more things attached to baby. But this is the most you probably would get on a baby right here in our NICU in St. Lucia. So who would you expect to meet in a NICU? Of course, you have your neonatologist, which is a doctor who has specialized in neonatology and, of course, would be there present to give his expertise in that area. Followed by our house officers, which are doctors who come underneath. They are not specialized in neonatology, but they do have experience with working in pediatrics in neonatology. So they are more than equipped to deal with the conditions that the babies have, etc. Followed by our nurses. You would also meet nurses. Each nurse would be assigned, of course, to different patients. So whichever nurse that is assigned to your baby would know what is going on with your baby. That is who you would see to interact with, to ask questions, etc. And of course, detailed information about your baby would be disseminated by your doctor, right? You would also, well, we don't have this here in St. Lucia, but in the first world countries who have level 3 and level 3 and level 4 NICUs, you would get a respiratory therapist. So these are persons who man the ventilator. They are equipped with knowledge to work the ventilators that baby are on. They know the different settings. We, the nurses in St. Lucia, we're our respiratory therapists. And the doctors as well. We know our ventilator settings. We know what works. If baby has a condition, a respiratory condition, we know what settings to put on there to man that condition, etc. But that is actually the job of a respiratory therapist, which unfortunately we don't have. But in, like I said, the first world countries, they are well equipped in that region. You also have your radiologists. So radiologists would come, especially since it's a critical unit. Babies can't always go down to the radiology department for ultrasounds, for x-rays. So they come up to the radiologist that comes up to our unit to perform x-rays for the babies and of course ultrasounds, etc. You would also have our pharmacists would be on the team. You would not see the pharmacists there in the NICU, but of course they are part of the team to ensure that babies get the medications that they need, etc. There was one I forgot to mention, the interns. We have interns with each house officer, so of course you would get to see interns shadowing their house officers, learning, so that when they do finish with their rotation, they can be placed in the NICU or in other areas of medicine. So these are all persons that you would see or may come into contact with on the NICU or in the NICU rather. So like I said, this is a very short video. There is so much more, so much more that we can talk about when talking about the basics of NICU, but this would have to be in separate videos because then I would be here for days. So like I said, guys, those of you who have not watched my previous video on NICU nursing, please go to watch that so you could get a clearer understanding of what I'm speaking about in this video today. And of course, don't forget to like. If you have not, just stop, pause, like this video right now. Share it. Go share it in your Facebook, on your IG stories. Go share it right now. Subscribe to the channel if you have not already. Please just hit the it's not going to take a second. Just hit the subscribe button right now. Turn on your notification bell, so when I do upload videos, you're up and on that. Yes. And of course, comment. Let me know what you think about the videos. You're not watching. I'm not getting any engagement. Do you like the videos? Are you getting anything from my content? Is there anything that you'd like to see me touch base on? Please, 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 let's get some communication down here. But thank you guys so much for always supporting, always giving feedback, whether it's in person or via private mediums. I want my feedback here, so comment. Always a pleasure, guys. Love you.
Oh